a young surgeon from Allahabad, and he will be talking about managing pre-existing astigmatism. So that is again a very, very important topic for all of us, that if we can correct the astigmatism which a person already have, or we don't induce the extra astigmatism, so he will give you the tips that where to place the incision, what depth and what. So Dr. Pranav, please.
Yes. Thank you so much, sir. At the outset, I would like to thank AIOS and Dr. Malik, sir, Dr. Ruchi ma'am, Dr. S.P. Singh, sir, and Dr. Sanjay, sir, and Professor Kamaljeet Singh, sir, for giving me this opportunity. So I'll be speaking about astigmatism management. So as we all know that technological advances in ophthalmology has grown by leaps and bounds. And it is not only our duty to improve the patient's vision, but also to refine it. And a proper management of astigmatism can lead to excellent visual outcomes and to achieve emetropia as the target nowadays. So what are the goals of the surgery? It is mainly painless visual recovery, spectacle independence, correction of pre-existing astigmatism, repeatability of a surgical result, and sustained quality of vision. So coming to the basics, as we all know that against the rule, astigmatism is the one that we deal with in cataract patients and in the older patients. So we'll deal with that. And what are the factors affecting astigmatism in SICS? So they are mainly incision characteristics, the use of cautery, the use and non-use of suture. And we'll deal with all the other factors individually. So the most important thing is that we should give a proper pre-operative assessment of pre-existing astigmatism, because accordingly we'll manage it. So how do we measure astigmatism? We can do it with retinoscopy, keratometry, and corneal topography. Corneal topography is the one that we use these days. But manual keratometry still has a role, and it is used in patients where there is poor fixation, corneal abnormalities, distorted Meyers, and highly toric cornea. In the rest of the cases, we usually go for topography. So how do we correct astigmatism in SICS? Mainly, these are the characteristics. The size of the incision, the larger the incision, the greater the flattening, and the smaller the incision, the lesser the flattening. So the larger the incision, the more the astigmatism, and smaller the incision, the lesser the astigmatism. The distance from the cornea is also very important. The farther the incision from the cornea, the lesser the astigmatism, and vice versa. So this was based on a concept which was given by Cox, and he said that the target should always be to hit the astigmatically neutral zone. So what is the astigmatically neutral zone? It is mainly derived from two important equations, as we've already talked about, that surgically induced astigmatism is directly proportional to the length of the incision to the power cube, and it is also related to the distance of incision from the corneal center. So the concept is based, like the funnel is based at the limbus, and as it moves away, it widens. And if we make an incision here, it should be astigmatically neutral. So this was quoted by Cox at that point. So the other thing that we should be aware of is the incision type. There are multiple incision types. We can go for a superior incision, temporal incision, or a superior-temporal incision. Superior incision are the ones which are easier to learn, and during post-graduation days, we used to give superior incision. There is better wound protection and lesser foreign body sensation. In temporal incision, we correct the astigmatism, because we've already talked about that against the rule, astigmatism is the most common one that happens. It is easier in the deeper socket patient. It is also easy in small eyes, and the best thing is that it preserves the conjunctiva which is there in the superior end, which may be useful for a future trabeculectomy. So the site of incision is important, and the concept is based on coupling, which states that flattening effect is achieved at the tissue and steepening is produced 90 degrees away. And this, if we give an incision at any place, it is usually, the size is 6.5 millimeter incision, it usually gives around -1 to 1.5 diopter of astigmatism. So again, when we flatten one meridian of the cornea, we will steepen the other meridian, as stated by the coupling rule. So this was a study which was done to see how much surgically induced astigmatism is seen in SICS. And it was seen that superior temporal one was the one which gave the least amount of astigmatism. And superior one is the one which gives the most amount of astigmatism. The incision length is also very important. The larger the incision, as we already talked about, gives a larger amount of astigmatism, surgically induced. So the other thing is cautery. In SICS, usually many places use cautery, and excessive cautery can increase astigmatism due to scleral shrinkage and scleral necrosis. So we should be aware of that, and we should do very minimal cautery in all the cases. So how to correct this pre-existing astigmatism? Mainly in mild astigmatism, we should always operate on the steeper axis. it can be neutralized by changing the site of the incision. So wherever the steeper axis is on the corneal topography or the keratometer, whichever you have, we have to operate on the steeper axis. The other thing is limbal relaxing incision, which are given at 90% depth, and it is around 600 mu depth, and it is given on the steeper meridian, as we've talked about, and it should be given just in front of the limbus. So this is a video depicting a limbal relaxing incision. So we make the tunnel after making the incision, and we do not enter the anterior chamber right now. And to cancel out the surgically induced astigmatism, we can make a limbal relaxing incision on both sides. So it is imperative to check the calculations to prevent any mishap, and usually a 90-degree off is the most common error. There are multiple nomograms given. There are online calculators also which you can do to see for the limbal relaxing incisions. Whatever amount of astigmatism you want to correct, you can just put the settings, and it will give you the amount of LRI that you have to do. So this is another Miller's nomogram. There is Gill nomogram. All of these can help in giving the limbal relaxing incision and planning the surgery. So what are the advantages of LRIs? It is mainly that it gives a lesser tendency of shift in the resultant cylindrical axis. It gives lesser tendency for irregular corneal flattening and irregular astigmatism, which are mostly seen in arcuate incisions. It is easier to perform than shorter and centrally placed corneal relaxing incision, and it is consistent with the coupling ratio, which we talked about. So the last method that we can use is opposite clear corneal incision. This was a theory which was given by Liver and Dahn, and they modified the standard approach to the clear corneal incision and adding an identical incision on the opposite side. So the technique involves creating two biplanar incisions, which are around 3.2 millimeter and 180 degree from each other. If it is SICS case, then we can make another incision on the opposite end. The only problem is that there is lack of predictability, there is absence of nomograms in this, and there are also increased chances of endophthalmitis because we are making such a huge opening there. So in conclusion, preoperative astigmatism, if the astigmatism is less than 1 diopter, we can make a frown incision, a normal incision in the astigmatically neutral zone to reduce the surgically induced astigmatism. And in a case of a moderate case, we give a small incision along the steeper meridian, about 6 millimeter, and straight in relation to the limbus, because that will correct higher amount of astigmatism. And in cases where there is higher amount of preoperative astigmatism, we can give a combination of LRIs, opposite clear corneal incisions, and the incision profile. So post-operative, we can manage with astigmatic keratotomy, wound revision, and excimer laser. So the take-home message is that careful identification should be done, and a pre-operative examination is a must. Astigmatism correction techniques are best chosen with the step-ladder approach, which I have already shown. And these techniques can be combined to give a higher level of correction, and we should always apply the incision on the steeper axis. Thank you so much.
Thank you, Dr. Pranav. The very important topic, and I think worth following, that we can correct, like in my life, I have never used the toric lens. My patient can't buy, and I wouldn't manage without toric lens. So in the SICS, I never really needed the toric lens. ये फेको वाले तो रोज डालते हैं right left और everyday toric because it's an expensive thing, not cheap.